I'm Mary Lloyd Ireland. I served as the program chair for the ACL study group for 2014 in Cape Town. I got to know Dr. Muller's work as a resident when I bought his book, The Knee, in 1982. We were fortunate to be with Dr. Muller and his wife Ursula at Londolozi. Londolozi is a private game reserve outside of Kruger National Park. The translation of Londolozi is protector of all living things. It seems that Dr. Werner Muller has been the protector of the knee throughout his long career. His presentation is The Knee, My Way to Understand the Complex Function of this Joint. He brings good wishes from Basel, Switzerland, and it has been my privilege to help put together this presentation for all of us to enjoy. Thank you, Dr. Muller.
In the late 60s, we had a resident from Spain, Pedro Rabona, and he always on the way back, he went to Lyon to see there, and when he came back from vacation, he was again 1 or 2 days in Lyon. And he said, yeah, what you do on shoulder, elbow, hip and foot here is good, but nobody knows about the knee in your clinic. So that was just a stimulus to do more about that. I went there to see in Lyon what they did in 72. Albert Ria have continuously your doubts about what you do, he said. Henri de Jour looked critically at all the results and compared the results. Gilles Bousquet was exploring with long incisions, and so we could see what was ruptured at the same time in combination, and he was the one who taught me first time about Hopiteus. And Paul Drummond there, patellofemoral problems and the shoulder, that was his strength. Importance of clinical examination was something I saw in Lyon. History, observation, examination, listen, look, examine. And then the indication for operation with calculated risk in the interest and for the profit of the patient. That was also something what they taught me. Future needs origin. We must learn from experience, but we get experience only when we have needed it before sometimes. The most dangerous day for a patient is the day in the OR after a contrast. So we had this, that is from a museum, from a personal museum, from a famous surgeon who did at that time all the meniscectomies in stable knees, and then they could kick a little bit more time afterwards, but never through. And he was always saying that the meniscus is regrowing because that's why we can't take it out completely. And I must say, I had a time when I also have taken out meniscectomy. Tavernier, when in 27, already warned about not to do easily meniscectomies. He made a transversion incision to the knee to see if it was really lesioned and if one could not repair it at that time. And then, in my early days, in the 60s, I really also have put ligament ruptured knees for 12 weeks in plaster, and we had to see that worked. Unbelievable for nowadays. And then we did these Lindemann type of things, active, passive reconstruction with the semitendinosus tendon for ACL and PCL. The idea was genius, but still it did not work so much. Then we did these peripheral reconstructions as Mock did, and gave it, and we did, when I was the first time, after that what my friend said, Pedro Rabona and Dirk Vermeeren, I went to Lyon again, and I saw Albert Ria on his conference then in 1970 or 72, and I experienced in Lyon the second dimension of the knee, when before we had only looked in one plane to that. O'Donoghue and Don Slocum have been there, and they have presented their operations against rotational instability. And look what they did for cruel things. Philippe has already shown this picture. They've taken away the meniscus all along the round until the PCL, and then they fixed it 2 centimeters more distal to the tibial head, to the bed, where it's shown. Crazy methods. Less crazy was Donald Donahue. Was Slocum with his pace and Serenus transfer. I did some of those. I did some of the O'Donoghue types. They're crazy nowadays when I look back. But we did from this in the clinic. I didn't personally this, but then we had these crazy methods as the 5-in-1 type. This I did never do, because at that moment I was just further away from destructing knees like this, you know, to take away the medial collateral ligament on the femur and to put the meniscus away and put it up and screw all the ligaments around down again to pack that up. And then look, 52 cases in 10 years and 23 complications and 17 failures. So they were at least honest. Right? And then, but why did all these operations not restore normal knee function? My AO experience showed with anatomic stable reconstructions, even with severe and intra-articular fractures and with the possibility of early motion, we could obtain an almost normal function of these joints. We not know yet about the real biomechanics laws of the kinematics of the knee and its ligaments. Then, next important step for me was when the anatomy professor of Basel, Arthur von Hofstetter, confronted me in October '74 with Alfred Menschik's work about the 4-bar link system and the biometry of soft tissue kinematics. The cruciate ligaments are the 4-bar link system and determine the form of the condyles and define the regular rolling gliding mechanism. These cruciate ligaments are precisely placed, structurally strong, crucial elements, as Fagin said, crucial elements for the guidance. The biomechanics of the four-link change was older. In 1836, the brothers Weber have done it. Menschik showed us later on the Burmester curve, and that Burmester curve had an influence on the position of the ligaments in the periphery. This was also something special. The cruciate ligaments 4-bar link chain shown here in this specimen, and here you see already the importance of the menisci, how they go around and how they give containment for the condylar for the two condyles. The cruciates, ACL and PCL, guide this movement of the rolling back. There is some difference in how much they roll back, at least it rolls back. In December '74, Kostrick from Toronto demonstrated us for the first time the pivot shift in our clinic in Basel, but with no pathophysiologic explanation. The years before, all the big six in the US, knee surgery used and done in Slocum, Kennedy, McIntosh, and Nicholas discussed during all the meetings over the years the pivot shift. But the pathophysiologic reason still remained unclear. The entire Christmas and New Year's time, my brain was working, and I finally wanted to get out what is that pivot shift, what is the pathophysiology of it. And finally I got it. The pathophysiology of the pivot shift mechanism, the rupture of the anterior cruciate ligament disrupts the 4-bar link system and breaks the rolling gliding mechanism down. The condyle rolls too far backwards and then snaps again forward and goes into the demanded correct position of that flexion angle. That's what I had in my book then. When I pivot, my knee shifts, the explanation which was from McIntosh and Losey. And these are the pictures in my book. You can very nicely see with photographs on the right side that the IT system is so tight because it's now sublux, the tibia forward, and then it snaps back into the regular position. And just to show you, that are my very first drawings, primitive drawings, which I gave in Leipzig in '76 in a discussion in on the paper when they have invited me in the East Germany, because they saw immediately in Basel that I had something special to say. And this is published in the, oh my goodness, now it's off. And not important. In the Zentralblatt für Chirurgie, which was in East Germany at that time, and that's why nobody knows it. And then I came to this situation. We had X-rays with broken wire things. I thought, what is this? We got these cases, and then we looked to that again for Balling chain. Now somebody has placed an ACL with sutures of metal, and when the knee was extended, the two ends were quite close together, and when it was bended, they were far away. So I had the proof that this four-balling system has to be placed on the correct position. And look also when it is too far forward, it is too tight, and it can re-break. And what is in this case so important is if you put that too far forward with a very stiff implant, you destroy the medial compartment, because all the compression goes to the bone and to the joint, and within a few years is like this. So it shows that all that system of the four-balling system was true, and it had to be regular. Just afterwards, all these operations which have been done for correcting instabilities here and there have been disappearing in the conferences, because now there were not any more logic, and even if somebody came and said he had 80% of good results, nobody could believe it anymore, you know. So then what to do to replace the ACL? That's Bruckner's technique, also in that Zentralblatt für Chirurgie in East Germany. He has taken a free graft of the patellotendon, like others did before, but that was at the time again in. And then we took Clancy's idea, because we didn't trust so much on the free graft, and took the patellotendon and let it pediculated on Hoffa. Then we turned it, and this is a heavy slide, but what's very interesting, the pediculated one in the middle above, black and white, shows that there is a disorder in the ligament after 2 to 6 weeks. And on the other hand, the non-pediculated in a sheet model showed at 2 weeks already new vessels along the fibers in the fiber scaffold. So we did this and went on to the free graft. And then where to place? Looked at the length, the individual length of each knee, of the form of each condyle and coupler curve is determined by the individual length relation between ACL and PCL. Look these different condyles, how they are, and that the insertions are really different. The model is correct, it's like faces, you have 2 eyes, a nose and a mouth, but everyone is different and you can see it. And then I got this from Menchik, who showed us that with the Burmester curve you can have the peripheral ligaments stiff bars as it is here, and it can be moved and it follows. It was interesting to know for me that you also have to regard the periphery better than we did before. And you can see that the axis of that rotation is almost about the crossing point of the 4 ligaments, medial collateral, lateral collateral, and the anterior and posterior cruciate ligament. Now it's another scheme, and we see on the right side also for the lateral side. And the lateral side is the rotating side that's moving, therefore all the ligaments have to be dynamized, and or they are not fixing femur to tibia as a lateral collateral ligament who goes to the fibula, and with that has some motional reserve in the proximal tib joint. So we had this, and we looked at this. Professor von Hochstetter gave me this wonderful preparation showing about how the normal medial collateral ligament with its longer fibers is almost corresponding to that what the theory with the Burmese curve is giving. And here you can see that again how the system of progressively recruiting fibers works in the knee in many places. The MCL, and then in full extension all the POL is tightened up, so when in extension and the knee is at risk against valgus trauma, all the fibers together with the meniscus are tightened. Then I had an extra experience. Don Fagan here, he came to Berlin in '84 at the Berlin Congress, and he visited me at the 12th of December, I know it exactly, in Bruderholz. The turning point was that for my life. One fruit was the start of the AOSSM Traveling Fellowship, but there were other things. In January '85, I could go and give the first Kennedy lecture in Las Vegas. It's there where I met Scott Dye. Scott Dye showed me a lot of preparations, and was astonishing that in his right preparation of an NCL, he had exactly found also, like the Burmese curve, that the position is like this. And even for the peace tendons, which had to go down and insert just in front of the distal insertion of the medial collateral ligament, it was for me a revelation to see, yes, nature is right, and that the theory of these Burmese curves and all that shows something. Maybe different from here to there a little bit, but at least it works. Then we had to go to the third dimension, the rolling gliding system on the left, and then turning around the pivot. This was the next step to find out. For the rotational control of the cruciate alone, the lever arms in the center are not long enough. They need help from the peripheral neighbors, the menisci. ACL and PCL with the menisci form what I call the enlarged central pivot. And this is the containment. If you look at this, the medial meniscus on the left is also has a gliding part to the back, and the lateral much more. And from above you can really see the containment for the condylar rolls, and you see that the capsular and muscular function around is okay. And laterally there it's a little bit the thick capsule is mid-capsular used in ligament, the second ligament, the ALL or whatsoever. And it is that what we called the lateral femoral tibial anterior ligament at that time. And now look what these menisci do. Look precisely. It's a little bit, a lot of it in that picture, but in exorotation, a line above, the condylar roll gives pressure back to the meniscus and puts it back. And if in internal rotation, the condyle goes forward, there is a space between the meniscus and the condyle in the back, and then that shows the mechanics of the medial meniscus during the external and internal rotation. And if we look at the lateral side, in external rotation, the meniscus is pushed back, it goes back forward. And in internal rotation, it is pushed forward, and in internal rotation, it is pushed back and far back, as you can see on the lower line at the right side. This is the motion of the menisci helping to control the rotation together with the cruciate ligaments. And what Rolly Biedert, who was working with me quite some years, has found out, we looked in all joints on the talar joint and here, the concentration of proprioceptive nerve elements. And you see all where the meniscus is, and the quadriceps, reclinoculum patella, the meniscal ligament have among the most important concentrations on nerve endings. That means that they are important to guide us and to steer the peripheral musculature controlling that. So we had finally the 5 peripheral ligaments around the 2, medial collateral, posterior oblique, popliteus, lateral collateral, and IT system with its fibers from Kaplan down to here.
The containment for the rotational control, plus the central pivot and the 5 peripheral ligaments. On the lateral side, we have the biceps tendon, the popliteus and the lateral collateral ligament and the ITBB system as dynamic stabilizers. On the medial side, the medial collateral ligament and the POL. When I pivot, my knee shifts. That's what the patient said to Dave McIntosh and to Ron Losey when they described the subluxation of the ACL insufficient knee. What happens? The ACL is ruptured and the lateral condyle is rolling much further back than it would be allowed by a controlled 4-bar link system. Then, when the ITT system is passing over the axis of the lateral condyle, the femoral condyle snaps back into the normal position where it should be with a controlled 4-bar link system. On the slides on the right, you see the tension of the ITT system before the knee in this sublux position is snapping back a few degrees of flexion later. Then is an anterior cruciate ligament rupture. Is it possible with isolated and a pivot shift? Pivot shift with isolated ACL rupture does not exist. You see on an old decennian old slide of a right-on slide from myself on the left, then with the following pictures towards the right, and what we did even more than 16 years ago. I was retired with 16 years, so these pictures are 20 or more years old, and show how we fixed the lateral meniscus back to the posterolateral capsular structure. And this was effective. Now, should one break a wheel on the axis or on the rim? The central pivot with ACL and PCL in the center have weak lever arms against rotation, and that's why the periphery is important to keep rotational control. You see on the bottom and on to the right, that's what we called an unhappy triad in the 70s when we had these complex injuries in ACL with the medial periphery and even with the POL, which is in this case torn away completely separately from the condyle, as you can see on the right. Then the POL as a secondary restraint to the ACL and PCL. The peripheral restraints have been shown by Noyes, Crude, Butler, and Lonnie Paulos. And in this case, you see in the drawings how the POL functions together with its medial meniscus, which is so important as a restraint against the anterior dislocation and as well to the posterior dislocation, because the POL is almost parallel also to the posterior cruciate ligament. The 5 central stabilizing periphery secondary restraints, together with the central pivot, here in details. Above left is the MCL and the POL with its attachments to the medial meniscus. Below is an isolatic preparation of the POL, which was described even in 1853 by Meyer in Zurich already. On the right side, you see the restraints of the lateral side on the POL, with the lateral collateral ligament, the popliteus system, and in the lower row, the Kaplan fibers of the ITT system, and you see how thick they are if you look at those closely in a fresh case with anterior cruciate ligament rupture and lateral periphery. The popliteal system, the LCL and the midcapsular third ligament on the lateral side. You see it just a little bit in front of the popliteus hiatus, and Houston has called it a midcapsular ligament, and probably also the second ligament, and the AAL of Stefan Klaas is included in that previously known midcapsular ligament. Now back to the ACL. It starts as in the embryonic phase, almost along the most isometric line of the anterior medial bundle. And then, when it's in use afterwards, it shows the system of progressively recruiting fibers very clearly, following the mechanical demand around the most isometric line. The ACL needs more fibers in extension when the lever arm is shorter than in flexion, and the PCL needs more fibers in flexion when its lever arm is shorter in flexion. Then the femoral insertion on the ACL, fully back on the medial cheek, posteriorly to the transition line, which is marked by the clamp. Then Georgis in 1975 showed the fiber system of the ACL as a type of fan in extension and in flexion. The anteromedial bundle serves as center of rotation, and the posterolateral bundle, the so-called one, is going under it and rotates around. Then how many bundles should we have? 1, 2, 10. Above left is a one bundle fixation, and then in the middle is a two bundle fixation on that wonderful picture of Philippe Colombe. Then down on the right we see the drawing of Dorothy Momothy's thesis in Nijmegen. In each ACL she found 10 to 6 to 10 bundles which could be distinguished. And now something which got absolutely overlooked because in 1890 in Munich, Manfred Appel and Gradinger, they showed with ideal preparations a kind of crisscross structure in the ACL. And I had a phone call with their chief, Professor Putz, before I came to Cape Town to ask about how they did it. And they said they did a wonderful and precise job, and he can stand fully behind it. They did not continue as it was prepared because Manfred Appel had to go out of the clinic and go into the private practice, and then he could not continue this special work. As we did it in 1982 with two bundles, and as it is done now in my former clinic by Marcus Arnold, in one anatomic reconstructed bundle. Then we have to mention also the DIS system, Dynamic Intraligamental Stabilization, as the University of Bern team with Stefan Eckli does it. They bring the stump together and splint it with a suture through it, and the suture is put in with a tiny spring that allows motion without distending the formed suture of the stumps, and then it's wrapped with a collagen membrane. And at 6 months, down at the bottom right, you can see how it looks like. The preliminary data they have is 300 cases in more than 3 years. Side-to-side difference at 6 months 1.8, at 12 months 2.2, and the VRS subjective measurement is 9.8. The knee and the ACL. Where are we now? There's still a lot to think about what's best to reconstruct and to bring it back to function to protect the knee from ongoing osteoarthritis afterwards. Thank you very much for your attention.